Hi, everybody. I'm Lindsay Covington. I'm the Director of Communications and Community Engagement here at Lake City Hospital. I just want to first of all say thank you all who are here in the room with us today. It seems like we have a full crowd, which is awesome. And we have people that are online with our Facebook Live today. So we appreciate all of our viewers that are online joining us today. This is another presentation with our HealthCARES educational series. So we're really excited to bring this back for the new year. We're starting off with Dr. Wang. He's going to have a presentation for us today about colonoscopies. So I'm going to hand it over to him and let him introduce himself and what he's going to present today.
Hi everyone, thanks for all coming over here in this room, and a lot of people I know they watching over the online or watching the video. So this is our, like we said, the third session of our education series. I'm Dr. Wang. I'm one of the general surgeon in the Lake City Hospital, and this is our office. And Dr. Vasikas is my partner and work in our office too. So all right, so let's go ahead and start. So our topic is about colonoscopy. So let's start this way. Everyone, raise your hand. All right. So if you had a colonoscopy already, drop your hand. Okay. If you know you don't need a colonoscopy, you already discussed with the doctor, and I'm nodding the criteria, drop your hand. Okay. So still few people still raise their hand. So I guess those are either you need a colonoscopy, you have not done yet, or you don't know if you need a colonoscopy, right? All right, we can drop your hands down. So these are the topic we're talking about, colonoscopy. Then hopefully after the session, you'll understand what is a colonoscopy. Do I need a colonoscopy? So, and you might have a better answer. All right. So first of all, I don't have any financial disclosure. I'm employed by Lake City Hospital. So let's start it this way to know a little bit about colon. Started from anatomy. So colon we call the large intestine. So this picture shows, by an anatomy, digestive system. You eat, go to the stomach, food goes to the stomach, then go to the small intestine. After food digested, all debris, all the junk, then go to the colon, started from here. So we call it cecum, and then the colon started from here, cecum, and you see ascending colon, which sometimes we call the right colon, and the transverse colon go up, and then go down, we call it descending colon, and this is a big twist, and then we call it sigmoid colon and connect to the rectum. That's the normal physiology anatomy of the GI system. So what we talk about is from all the cecum, all the colon, and all the way down to the rectum. That's what we're doing. So next. So that's the picture we know. That's a normal anatomy. See what actually human colon look like. Could be this, multiple loops. It's not like a door frame like anatomy, right? Normal anatomy. And it could be this too. So many twists. And it could be this too. You can imagine there's so many twists. So with all these loops of different colon, a lot of things can happen, especially the colon will store all the poop and the junk, right? So colonoscopy, what is colonoscopy? Like 2 words, we'll learn the colon, then we'll learn about scope. That's why the colonoscopy. This is what it looks like. So the scope is a tube structure, and we call it the endoscope. The other end connect to the screen. There's a camera on the top, and you have a different channels. We can do procedure, not only looking with the camera, we also have an instrument it can put in, and we can do the procedure. Actually here, I bought a real scope. If anyone interested, I could show you quickly. So this is the scope usually we use. And of course, there's different type. And this is what we use. And that's how I operate. There's 2 wheels. I can control the typical left and right, up and down. So this is how we do the colonoscopy. We enter the from anus, go all the way into the colon, and lubricate it, and go check each colon with the big eye and magnify all this, put on the screen. I can see detail each piece of the colon, each small space, if anything going on. So by looking, probably look like a little bit bigger my pinky size. Okay, so a lot of people just worry about when we do colonoscopy, what do you put in my body? So this is what we do. It's about probably 100 like 60 centimeter length. Most of the time we don't use the whole length, and that's what we call it. So at the end, if you're interested, come to take a look. That's what we use for the colonoscopy. All right, so like I said, we checked all the colon and see what's going on. And then the question is, why do I need a colonoscopy, right? So let's see this. In a colon, we're just talking about a lot of disease can happen. And it can have all these adhesions, and ulcerative colitis, and the polyps, the lesions, Crohn's disease, and diverticulitis, all cancers, all these can happen in the colon. And when we do the colonoscopy, we put a camera into the colon, we check all the colon, see what's wrong with it. So most importantly, we talk about colon cancer, colorectal cancer. So in the US right now, colorectal cancer is the second leading cause of the cancer deaths of both man and woman. By statistics, by number, it's pretty scary. The lifetime of a colorectal cancer in men is 1 of 23, and 1 of 25, like 4% for women. So most of colon cancer, colorectal cancer, started with a tiny and a small cells growing like a polyps. At the beginning, it's just small polyps. With the year going, with the time going up, usually it takes about 8 or 10 years to grow to cancer. So nowadays, we recommend it at the age of 45, because the risk is going higher. So at the age of 45, we recommended a colorectal cancer screening for everyone. Okay. So if you have any family member, first degree relative, we call it first degree, that's a parents, sibling, and child, if they have a colon cancer, or sometimes those family member, they diagnose the colon cancer younger than 50, and you definitely need a colon cancer screening. So we talk about colonoscopy. You might heard of screening colonoscopy, diagnostic colonoscopy, therapeutic, and the surveillance colonoscopy. What are the differences? Which one do I need? Okay. So next, first is we talk about symptoms. If you have any symptoms. So those are symptoms including abdominal pain, bloody diarrhea, chronic diarrhea, and sometimes bowel habit change, and even bowel and stool caliber change. Those all the symptoms could be related to colorectal cancer. So if you don't have any symptoms, don't have any signs, and a screening colonoscopy can remove the polyps and find the cancer that could be early stage. And when we remove the polyps and decrease the cancer chance, and it'll give you a full recovery. Diagnostic colonoscopy, mostly we're talking about patients with symptoms. So if you have symptoms already, you have a chronic anemia, you don't know what caused the chronic anemia. You have a rectal bleeding, you have the change of bowel habit, and you have abdominal pain was not diagnosed. So you may need a diagnostic colonoscopy. Therapeutic colonoscopy is talking about patient already had a known problem. They know they have the rectal bleeding. We know they find some AVMs, you have a mass. So sometimes it had a surgery before, is narrowing, and sometimes they had a lesion removed and now possible recovered, regrowing. So these are called therapeutic colonoscopy. And for those patients, they have a colon polyps before, they had a cancer, they have inflammatory bowel disease on the treatment. So once in a while, they need a surveillance colonoscopy. So here are some videos, and that's what we saw when we do the colonoscopy. And so now you're the doctors, and looking at colonoscopy, what do we see? So that's the scope, we put in the colon, and the colon is insufflated with a proper pressure. So we can stretch the colon wall, you can see, then all the way down to the cecum. So the little hole, that's actually the appendix orifice. So that means we all the way go to the cecum. Then on the way out, if we see some stool, we'll kind of wash it out. Yeah, we spray the water. So that's another thing is when we go to the colonoscopy, we'll hope the patient get all cleared. We can see the bowel wall very clear, so we don't miss any issues. That's what we do. So going to the next case. So see what you can find. This is a little normal colon. The little thing hanging there. To us, it's a smooth and a regular shape, oval shape, and a little stalk. So that's actually a pretty big polyp. Okay. So when we see the polyp, then what we do, we put an instrument in there. There's a metal loop, and it closed up, and it give a little bit coagulation. Then the polyps will be disconnected. Right? That's how we do. And the little polyps is removed, and we suck everything out and remove it from patient's body, send it to pathology, see what kind of polyps is. Right? There's another case. Same colon, something in there, and almost half occluded the lumen. It's not look like a regular shape. A little bit ulcer on top of it, maybe a little blood you can see, right? So those are more like possible cancer. Okay. There's another case, obvious, ugly looking, right? And stick it out. It's not regular shape, not smooth, and on the rough surface. Those are more like, here you go. Those are more like a cancerous mass in the colon. Okay. So if we see the colon small mass, we take it out. Then what's the next step? Well, pathology. If there's a pathology showing that's a cancer, then you might need a surgery. So with those lesion or polyps or cancer in there, most of the time, patient has no symptoms. Until the cancer is big enough and the blockage of lumen started bleeding, you might have symptoms, and you have obstruction symptoms, you have a bleeding. Then at that time, we'll go back, maybe the cancer is already big. So that's what we do, colonoscopy, to find out the colon polyps or cancer at the early stage. So colonoscopy is the most accurate, that's what we're talking about, accurate way to find out, to remove the small polyps. And removing polyps at the early stage that we're talking about can decrease the risk of a death and from colon and rectal cancer. Currently, American Cancer Society guideline and colonoscopy is 45 years old for average risk. And 40 years old, if you have a family risk, increase the risk for 40 years old. So then people were talking about, is a procedure, is a colonoscopy safe? Yes, but it does. There's some complication can happen, but we can look at the data. And of course, there's a possible of a perforation of an intestine when we do the procedure when colon is insufflated. But the rate is only 3 events per 10,000. And there's a chance of a bleeding, but the chance is pretty low as well. It says only 14.6 per 10,000. And during the procedure, you are under moderate anesthesia, mostly sedation. And sometimes patient with background disease can cause a cardiorespiratory issues, but those are the chances you don't know. And other complications, more like symptom-wise, and not real complication, including sometimes discomfort in the abdomen, cramping pain after procedure. Sometimes you will have a little bit diarrhea, a little bit stool. Those are all, and some nauseous with anesthesia, with the procedure during the sedation. So these are the possibility. So remember the picture I showed you at the very beginning. Some people, they have multiple tortuous colon, multiple loops. There's another chance is because all the loops, we cannot always reach to the end. So these are in the very rare case. So everyone talking about the colonoscopy, but nowadays, I believe you heard about, how about we don't do colonoscopy? And some doctors recommended to me to do Cologuard. That's a no procedure, no risk. I just need to get a stool sample. Can I do that? Yes, I'll say this is actually one of the options for colorectal screening. And the purpose is a screening if you have a cancer. So these are all the techniques listed here. FOB test, mostly detect if you have blood in the stool, FIT, FIT, and sigmoidoscopy, and DNA test, and even virtual colonoscopy. So these are all the techniques you can replace colonoscopy to find out if you have a cancer or not. So what's the difference? Remember, when we talk about this, the difference, I try to make the table simple. Compare colonoscopy with a FIT test, Cologuard. Yes, they both or they all try to detect the colon cancer. And a Cologuard actually had very high detective, 93% you can detect the colon cancer. So the difference is colonoscopy not only detects if you have a cancer, but preventively you can remove the polyps, because those polyps in the future possibly can grow to cancer. If you do Cologuard, yes, you can screen if you have a cancer or not, but not preventively to remove the polyps. That's the major difference. So as an option, some people, they feel like, okay, I don't want to take a risk, and they're concerned about the procedure, or sometimes they have a underground medical condition. They cannot have sedation, all these medications. Yes, that you can use the Cologuard and for colonoscopy screening, colon cancer screening, but it cannot replace colonoscopy. And because colonoscopy, we can remove the polyps, which Cologuard will not do that. So summarize all these. And what you need to know is, if you don't have any symptoms, if you're 45 years older, regardless if you have a family history or not, and no matter your gender, and if you are Black or Hispanic American, your risk of a colorectal cancer is higher than normal. Okay. So we talk about all the procedure, and you might heard a lot of people, they had a colonoscopy, they heard, all right, so the colonoscopy prep, that's up. Okay, so let's go through it, see if really that's the problem. So the purpose, like I said, we clean out the colon so we can see better, we don't miss any lesion or miss any polyps that you need to take out, right? So from the beginning, before the colonoscopy, so usually start at 7 days. If you have any medical condition, diabetes, or your heart, cardiac issues, you're on blood thinner, so relative around like 5 days before the procedure, and you will need to hold off if you have a blood thinner. But talk to your medical doctor first if you are safe to take off the blood thinner. That's the first thing. But if you have high risk, you take off the blood thinner, and probably the procedure will not be good for you. So talk to your medical doctor, cardiologist, if you are safe to take off the blood thinner for the procedure. So about 3 days before your colonoscopy. So at the time, try to stop eating any nuts, seeds, popcorn, because those are staying in the colon for a long time. It's hard to get rid of when we do the colonoscopy prep. And at that time, try to get all the liquids you will need. But remember, no red, blue, purple, those are color. Okay? Because during a colonoscopy, we see blue, we see red. What is it, bleeding or something? It's hard for us to differentiate. So try to stay away for those, the fluids. So all you need to prepare is a clear liquids. is any liquids you can see through mostly. So these are some examples: Gatorade, Pedialyte, Powerade, and clear broth. And coffee, black coffee and tea without milk, that'll be fine. And some other liquids are listed there. Now getting close to colonoscopy, we get ready to prep. 2 days before colonoscopy, try to drink more water. Make sure you're hydrated, because during a colonoscopy, you probably understand you will lose a lot of fluids through the bowel. So the day on the up before your colonoscopy, so at that time, now we're gonna stop all the solid food, and then start all the liquids diet. All the liquids were listed before. No red, blue, purple. Those are any fluids with color. And now we're gonna start prep. So prep has so many different ways. You might heard different doctors and they give you different things for bowel prep. But whatever these, all the methods, the only purpose is to clean out everything in the bowel so we can have a clean colon we can see. So there is one, actually a very simple one. So this is American College of Surgeons recommended just 1 day method only with the Miralax. That's a standard that they recommended. So started the day before at noontime, take 4 Docolax. Those are the laxative, and prepare all 64 ounces of liquids with Miralax. Mixed it up, and they recommend it at 6 p.m. Start a drink every time 8 ounces, and take a break 15 minutes, and until you finish all these. So during the prep, drink a lot of water, and it is important that you replace the fluids and to prevent dehydration. Okay. So here's some tips. Okay. So you're gonna have a multiple diarrhea and coming out and clean the colon. Stay near the toilet, as you understand. Then if some patient, they feel like, okay, that's too much water for me, and every 15 minutes I drink 8 ounces, makes you nauseous, and the stomach is distended. So don't worry, it's not exactly 15 minutes. You can take a little bit longer time break, like 30 minutes, and rinse your mouth, make sure you get better, then you can continue. If really you did not tolerate all the liquids, did not tolerate all the prep, you did not finish, make sure your doctor aware. And so we're not going in, actually you did not already prep. So make sure your doctor aware, we can discuss if any other way, or sometime we can do another time. So sometimes when we do the bowel prep with all the liquids drinking, you'll feel some bowel abdomen as a cramping. That's totally normal. And the other thing with multiple diarrhea, and it was recommended to use some Vaseline around the anus, like a baby wet. That can help to decrease the irritation. All right. So on the day of a colonoscopy, make sure someone with you, because after the colonoscopy received sedation, someone needs to drive you home. So during the procedure, and especially in the morning, and if you regularly take medication, you can still take your hard medication, some other medication, you can still take them. Okay. So all these, that's the day we had a colonoscopy. So I have a friend, they posted a video, and you know them too. So he said, this is my first vlog of the first colonoscopy. Let's watch that. I turn it up a little bit, I'm not sure that.
I'm here with my doctor. This is Dr. Ayla Stanford.
That is me.
Wow. We are in Miami, and I'm going to have a medical procedure tomorrow. Colonoscopy. So,
Necessary.
yeah, so we got, because I'm 50.
See if they can make it louder.
All right, but we're going to talk about it.
popular murder scene. CSI Miami would have you come check the 12 o'clock. It was at 3 o'clock. It was like, you could tell the picture had come in from the 12 o'clock. And then at 5, it was just. I guess in that description is just water. Because my boy don't slip socks. Because my gown, it opens to the back. From the out. So they can get to it easy. Come on, be out. There we go. It's official. Definitely no darting today. No important decisions. So no part auctions. No. No party. You're gonna hate that $400,000. It's only gonna be about an hour. I'll be covered. Okay. All right. At your service. All right. You did. All right. The best part of this is when you come out the other end and start waking up. I would be saying, I'll be all bad. What do you want to do? The best part of this is when you come out the other end and start waking up. I would be saying, I'll be all bad. I'm getting that. I'm sorry. So this is what I found. You should start feeling a lot better.
Hello, how'd you do?
Hello, Mama.
You all right? Yeah.
Good question. Did you guys do it?
I did good. You look like you did okay. You doing good? If you did okay, you're doing good. And your doctor, she's still talking about the burrito, but they'll both be over in just a second to see you. He's going back to sleep.
That's some ice water right here. You want something to drink?
Yeah, filled it here. Right.
We ran out of that. I'm sorry.
Only thing he has before 9 a.m.
There you go. But that wasn't as good as we would have liked. There's still some solid stuff in there, but we were able to ensure that there's nothing outside that. Okay. Especially, thank you.
Yeah, so we came in for the screening colonoscopy today. Everything went well. All the vital signs ahead of time were good, no complications.
Then what's Will's current state right now?
So he is in a fugue, I would like to say, having received some anesthesia to receive the procedure, so no important decisions being made today, and just relaxing. That's it.
So we're done. I had my colonoscopy. I feel thoroughly I feel back. I'm totally back. Everything feels normal. 2019, gotta get our health right. There's a certain amount of commitment and
Is that encouraging? Right. So we learned all the colonoscopy. Now we see this is a real experience. So I stole it from the YouTube. So he actually, the Will has a channel for education to educate the people to get colonoscopy. So I don't think he will mind. I get a video and for education purpose, right? So all right, so we learn all the colonoscopy, and this is a real experience. What we're gonna do? March is a colorectal cancer awareness month. If you have not done so, or you still have a question, come to us and talk to us to find out if you need a colonoscopy, or if you think you have any question you discuss. And this is our office. There's a number you can call anytime, and so we can talk about colonoscopy. We'll find the best way to do. So in our office, we not only do colonoscopy, we're surgeons, general surgeons. So we also do a lot of other surgeries, gallbladder surgeries, and hernias, and the GI surgery, including colon cancer. If we find a colon cancer, we can do resection, and diverticulitis, hemorrhoids, of course, EGD, colonoscopy, we do biopsy, polypectomy. Those are all procedures. Some are skin and soft tissue surgeries. We do all these surgery too, including emergency surgery when we are on call. A lot of emergency surgery, we do that. And a dialysis access, and these are all we can do in a hospital. And robotic surgery is another aspect of our practice, and I will use a robotic surgery as a minimally invasive procedure to do a lot of surgeries. So this is one of the surgery we do. And also recently, I went to the WCJB TV20 to introduce a little bit about the minimally invasive surgery. And this is a picture actually from last year. In the middle of the last year, we finished over 1,000 robotic cases. And right now, I believe we're going to add another few hundreds on. And this is our excellent OR team. So Lake City, we offer broad spectrum surgeries. So general surgery is one part of the team, and we have a state-of-the-art updated surgical suite. And you can see, and this is the building. You may notice as well. There's a new tower is under construction. Should be done sometime this year. So we have a more OR room and provide more care. So as our hospital, we try to provide all the care that family needs, and you don't have to drive hours to go to other city. And we'll keep our patient here, and all family members, they can take care of it close to home. So last, a little bit about myself, and my name is Wang, and you can call me Wilson too. I'm a board certified general surgeon. So I was raised and grown up in Shanghai, China, and I came to the state 20 years ago. I was a neurosurgeon when I was trained. I was practicing neurosurgeon when I was in China. And I came to the research. I published a lot of paper in the neuroscience. I want to get back to the practice. Then I went back to retrain to get board certified as a general surgery. I was trained at UVA Medical Center, Cornell Lincoln Medical Center, and a UPMC, Central Pennsylvania. And I became board certified general surgeon. I'm a associate fellow of American College of Surgeons, and a lot of membership in the professional society. Now I moved to from Pennsylvania to Florida. I can still ski on the beach. I can have a sunbath in the snow. This is my family. I have 3 boys, and my wife is a transplant nurse practitioner. And I enjoy the time. I go to community, give a lecture, give some education. And also, I love the time. I enjoy the time when I went to Africa for a mission trip. These are all the patients I operated when I was in Africa. So my practice, mission, and a vision, I use the 2 verses in the Bible. I'm so lucky to have the gift from God, have knowledge and a skill. I would like to use my knowledge to serve my neighbor. I love my neighbor as myself. My goal is to build a practice that is not just known to excellent surgery, but also for compassionate care, promoting healing and wellness in our community. I want every patient to feel heard, respected, and confident they are in good health. At the end, thank you all coming for this lecture and all the friends and watching over the video. And I'm here to help like your neighbor. I look forward to serving you and your family in the years to come. At the end, so this is our Facebook page, Lake City Hospital Facebook page. Make sure you sign up. So every time we have education series, you can get on the live stream or you can review all the video we had. At the end, any question you have here or any friends online have any questions? Yes, sir?
So they tweaked that guideline for first colonoscopy in the last few years, right? Didn't it used to be 50 and it's 45
Correct.
now?
It is. So you notice in the video, will get a colonoscopy 50 years old. So at that time, that was a few years ago. So at that time, recommendation is 50 years old. But with the time changing based on the study and the risk of a colon cancer, age is getting lower. So now the current recommendation is start at 45 years old. So the move lower. You're right, it was 50.
Okay. So the interval, if you have a colonoscopy that's all clear, is it 5 years still?
So that's a good question. And so based on, I didn't touch in the all the presentation. So you're right. If the colonoscopy is clean, there's nothing concerning. Every 10 years, you repeat a colonoscopy, start at 45. If you find out you have a polyps, and the plan will be different, depends on how many polyps you have, what size of a polyps, what's the pathology. Then based on the results, there are different guidelines need to be discussed. So sometimes could be 3-4 years, sometimes could be 5 to 7 years. Any questions? So this, here you go.
Is the age getting lower based on the food we're eating or lifestyle habits? Is that why the age is
I will say it's a multifactorial. So it's not clear what reason caused the risk of a colon cancer age going down. Sometimes could be food, sometimes the environment, and a lot of the reasons. So that's based on the study, patient would diagnose the colon cancer. Based on that, they moved the guideline to 50 to lower to 45. Okay. Anyway, this is our number, our office. Call anytime. Like I said, you want to get a colonoscopy or you want to discuss if I need a colonoscopy or not. And just call us, let us know. We're happy to discuss about this. Okay? All right. Thank you. Thank you. The scope is here.